Hello, good afternoon once again here at the ESC Live Studio, here in the venue in Paris, as well as online all around the world. It is my honor to have an opportunity to talk to my next special guests, who are Professor Xenos Petridis, who is the assistant professor at the Department of Endodontics at the National and Kapodistrian University of Athens School of Dentistry, as well as he works at the University of Groningen, and Professor Prasanna Neelakantan, who is Associate Professor of Endodontics and Alberta Dental Association and College Endowed Chair at the Mike Patrick School of Dentistry, University of Alberta, Canada. It's a great privilege to have you here.
Thank you so much.
Great to be here. Thank you.
The topic of our next 20 to 30 minutes will be very important. We'll talk about disinfection in endodontics, about current knowledge and clinical practice. So the first question to open this discussion will be to Professor Prasanna. And could you tell us why is effective disinfection still considered the unsolved challenge of endodontics despite decades of research and technological progress?
That's a great question. Now, I don't know if you can term it an unsolved challenge. It's a challenge which we have constantly established cognitive dissonance in. It's a topic that we know is critically important, yet refrain from understanding or developing the science more in that area. For years before micro-CTs, we thought anatomy was very simple, and hence irrigation strategies were very simple. And when we solved the problem of understanding complex anatomies, the microbiological challenges grew. We now know that organisms inside the root canal are not free floating, they are in biofilms. And we understand more and more about biofilms currently, that we also know none of our current strategies can eradicate them completely. So the challenges are twofold. One is when the anatomical complexity has been addressed, the biological challenges have taken over, and we don't do enough to characterize these microbiological structures in endodontics. Once that science grows, we will likely find a real solution.
And a question to Professor Xinos. Could you tell us from the chair side perspective, do you think our map of the root canal infection is still incomplete? And how does this affect treatment planning?
Now, thank you for the question. I absolutely, it's an absolute yes. I think it's incomplete because, as Prashant already mentioned, there are two major things that we have to consider every time. That is the anatomical intricacies of the root canal system. We are now aware of the fact that we cannot reach many areas in the root canal system, so we rely on chemistry, we rely on irrigation, and then we come to the next issue that we haven't mapped out yet really, and that's the biofilm. A biofilm infection is not about free floating bacteria that we can just take out with a simple irrigation protocol. There are things that we don't take into consideration yet, and maybe it's very difficult also in the future to take into consideration, like biofilm maturity. How long is the biofilm in there, and how long has been already established in the root canal? So I would say that that's pretty difficult. And from a clinical standpoint, I just try to and my advice is to maximize the irrigation protocols that we have established and we have data for today. Go with the best concentration. Try to optimize your time and volume of your irrigant, and of course, try to deliver the irrigant in the best way possible. And fortunately, we have a lot of devices today that enable us to do that in a more, let's say, predictable manner.
Have the opportunity to clean and disinfect as much as we know, as we could.
Yes, at least we try.
Could I supplement that? So, when we speak about disinfection, we constantly think about removing biofilms, killing bacteria, fine. But we also know that with anything we have today, full eradication is not possible. You're always going to have some organisms that survive inside. What we have not figured out yet, which we have known in the past 4 to 5 years, is how are you going to prevent these remaining organisms from reforming into a new biofilm? Because current microbiological knowledge tells us that these bacteria don't need elaborate nutrition to survive. And within the dentine, you already have fantastic nutrition in the form of collagen. So these organisms can multiply over time even without leakage from any other external or internal sources and still reform a new biofilm. So biofilm recovery is a very important, substantially understudied topic from the context of dentistry in general.
Great, great. Thank you very much. And now let's talk a little bit about research and practice. And Professor Prashana, biofilm complexity remains a challenge. Your reviews on biofilms, for example, from 2017, highlighted host evasion and the elusive threshold for healing. What remains the biggest blind spot in translating this into practice?
That's fantastic. So if I were to write that review in 2025, those bottlenecks still remain. We have not addressed that yet. I think there are two areas which we really need to look into, which is in fact going to be the focus of my talk tomorrow at the symposium. The biofilm comprises of not only microbes, but also a component called the matrix. Unless you collapse that matrix, you cannot kill these microorganisms. And what do we know about matrices in endodontic biofilms? Nil. We don't know anything whatsoever. The second thing, which we have recently discovered, we just have a paper submitted, we have discovered that within the endodontic realm, microorganisms can go hide inside mammalian cells and escape host defense responses. That remains to be addressed. And none of what we have currently can kill these microorganisms that are inside these host cells. So I think there are two bottlenecks. One is characterizing the matrix, so we know what can eradicate the matrix. Hypochlorite cannot. Clohexidine has no effect on the matrix. Our activation strategies may help, but we really need something new in irrigation which selectively can eradicate this matrix
To be sure,
component.
we can do it. And
Yes.
one more question: your 2025 meta-analysis on calcium hydroxide's effect on endotoxins. What weaknesses in our disinfection strategies did it expose?
Okay. I think the problem is that there is no one standard irrigation protocol we have. In different countries have different protocols. Consequently, the thought process is also reasonably varied, right? What our study showed us was that endotoxins were not completely neutralized by anything we have today. Hypochlorite was the most effective, clohexidine was not. But hypochlorite, again, greater concentrations work better. That comes with a potential toxic effect if you extrude, potential detrimental effects on dentine. So one of the ways by which this could be addressed is right now there's a lot of work being done with peptides. So antimicrobial peptides, which can neutralize these endotoxins, could be a potential solution to this problem.
And now, a question to Dr. Xenos. From a clinician's perspective, how should practitioners interpret these findings? Do you feel we sometimes overestimate the clinical power of irrigants and medicaments?
That's a good question. Before going into this question, I would like just to add
Of course.
into something that Prashana mentioned
Sure.
about the matrix, which is very, very important. And we had these problems when we were growing biofilms and we were trying to disrupt biofilms. And especially, we saw, for example, that chlorhexidine not only doesn't do anything to the matrix, but it also reorganizes the matrix in a fashion that does not facilitate further removal. So we kind of revisited the concept of using chlorhexidine in the past, and I think that nowadays chlorhexidine is for sure not the first weapon we have in the armamentarium to
Yes.
go with our irrigation protocols. If we overestimate irrigation, I don't know for sure. I think that sometimes we probably overestimate the role of medicaments and we underestimate the role of irrigation,
Yeah,
which should be
that's right.
otherwise, if you ask me. I think that most of the work is done during the chemomechanical preparation, and I think the randomized trial in which Prashana was involved with the continuous chelation showed that most of the endotoxins, that detoxification process happens during irrigation, during the first step, and not during medication. So I think that we should try to put more credit on irrigation, try to anchor ourselves on the basic principles. I mean, we know sodium hypochlorite is probably the best uh, that we have today, is the gold standard, and probably will remain the gold standard for a couple of years more, because it has so many potentials. I mean, it disrupts biofilms, it kills microbes, it detoxifies root canals. We should find the proper balance, and we should try to push the limit towards disinfection, and maybe put to the lower end our medication protocols. I don't know, if I have to choose, of course.
I'm completely on your side because the more we irrigate, the better for the
Yeah.
result. And the second question also to you, Professor Xenos, what are the most important take-home messages for clinicians when choosing irrigant protocols in difficult cases?
Now, first of all, I don't know. We should define what a difficult case is. I think a difficult case is a case when you know beforehand that you have a very complex anatomy, when you know beforehand that you have a long-standing infection, so probably you have to deal with an established biofilm infection. So in that cases, I would go. My take-home message would be stick to the principles that we have today, and try to optimize your protocols by probably increasing your concentration. When we talk about sodium hypochlorite, we know that we've seen that in practice. We haven't seen that clinical. We don't have clinical proof of that yet, strong clinical proof that it helps in terms of outcomes. Uh, but we have some surrogate evidence pointing towards higher concentrations. So I would say increase your concentrations, try to irrigate safely. Of course, when you increase your concentration, give time, increase volume, and try to agitate probably with whatever you have. I'm not in favor of a specific gadget or device. I'm not in favor of multisonic, laser, ultrasonic. You can go as simple as you can. Just do some ultrasonic
Or
irrigation, and
combine few,
probably
right?
or combine maybe some stepwise combination of everything will add incrementally, but we don't have a solid clinical proof, to be honest. So I'm trying to. My piece of advice is with the principles, stick to the principles, and try to maximize what we have. To be honest.
Great. Would like to
So
ask.
I have a slightly different take on that. Now, regardless of whether the case is simple, complex, long standing infections, my irrigation protocol doesn't change. I would irrigate like a crazy madman no matter what the condition is. Because most times we don't know what lurks beneath. We have no way of knowing what's inside. So I've been using continuous chelation for quite some years now, and I make sure volume. It's I use a minimum 15 ml per canal. I always agitate. So my preference, of course, is ultrasonic. So in terms of choosing activation strategies, I know there's also a cost benefit ratio involved. If you have much more significant expensive devices like multisonic, for example, is there a definitive benefit? Probably not. You would achieve the same benefit as with simpler activation strategies. But I feel very strongly about irrigant activation. I think, given how much of knowledge we have about anatomy and the microbiology, I think irrigant activation is a step that you cannot not do. You must do it. How you do it is secondary, yes, but my preference is ultrasonics.
If I can
Would
add
like to add.
something, I fully agree on that, because sometimes we are, let's say, taught that, for example, vital pulp cases can be done quickly and you shouldn't spend too much time. I fully disagree. It takes too much time, to dissolve the pulp. We should not keep our irrigants only for the complex cases. We should irrigate, as Prashana said, as much as we can.
Especially when we need to remember about isthmuses,
Of
all of
course,
these
of
hard to
course,
reach
and
areas.
always keep in mind that we create debris, so we add something that we need to remove afterwards. So we should be more persistent, if you ask me.
Right, great, great. It was very, very informative for our participants. And now let's focus a little bit about on device activation and anatomy. And Professor Prasanna, your review on novel intracanal medicaments, so peptides next-gen agents, which are closest to real translation and which remain experimental?
So peptides is sort of, let's say, the next big thing. Not just from the root canal perspective, but from general anti-infectives, because it's almost impossible for bacteria to develop resistance to peptides because of unique mechanisms. So we've been working with a peptide over the past 2 to 3 years, which we've just patented. So this peptide comes from a peptide that's produced by the human body. So we humans produce a peptide called LL37. So our host cells produce it to kill bacteria. So we developed a shorter version of that, and we are seeing incredible effects with these peptides. They are very biocompatible. They can disrupt biofilm entities. We have mouse models with skin infections, oral mucosal infections, root canal ex vivo models that it works really well. So if things go well, this is likely a next step forward. Now, one of the challenges when Xenos mentioned hypochlorite is the best irrigant we have, I was laughing also because not because it's only the best irrigant, it's also the cheapest that we have today, right? So for any new irrigant to come into the market, from a price point, it has to match the price of a gallon of bleach, which is almost impossible. So unless endodontics is a specialty, does what perio has done in terms of focusing on biology, on stressing to general dentists and specialists alike that the problem is the biology and not the technical complexity of things, then the cost factor becomes secondary. Right now, because biology takes a backseat always, cost factor is seen as a big obligation. But once we tell them that is the final problem, we may start adopting slightly more expensive materials if they are substantially more effective.
Good. And Professor Xinos, a minimally invasive shaping preserves dentin but may compromise irrigation, as we know. Do you believe current activation technologies really solve this trade-off?
Now that's a very hot topic. I think whenever we put the words minimally invasive in front of something, it immediately becomes a hot issue. Um, I always wonder, ask myself, and I also try to trigger clinicians or students to think like that. Whenever something is brought on the market, or whenever we something is brought to us with claims, hype claims that it's the best, we should see it from a patient-centered perspective. I mean, is it improving patients' life and outcomes, or it's just a lab hype? Now, we have a lot of in vitro data, if you ask me, showing that with minimal invasive preparations and, for example, multisonic agitation, we can remove a lot of stuff in terms of log reductions, and when we see PCR results, I mean, we remove a lot of stuff. Minimal invasive doesn't mean that we should not shape the root canal at all. And actually, if we go to the next level and we try to see what in vivo studies are demonstrating, I think there is a recent study published now from the Kohenka research group that they used gentle wave, for example. I need to disclose I have no conflict of interest whatsoever, where they showed that there is negligible differences between traditional irrigation protocols and multisonic irrigation protocols, even though they didn't perform minimal invasive root canal preparations. I think that from a laboratory standpoint, we have managed to accommodate this trade-off, but we're still lacking clinical data that we can go less with less tapered preparations and just employ irrigant agitation devices and solve the problem. There is always a trade-off. There is always some concerns. At least we have some more solid data. I think that, as I said before, we should rely on what we know that it's working, and not be close-minded, be open-minded to new findings, but also interpret everything cautiously.
You'd like to add
So
something?
the first question is a counter question. What is being minimally invasive?
That's true. That's true.
Let's say you're performing a regenerative endodontic treatment. Root canals are inherently large in those cases. The recommendation is to minimally file those root canals. Is that being minimally invasive? I think it's all contextual. What is the initial size? No one ever knows unless you take a CBCT for every case and measure the apical foramen diameter in 3 dimensions. You don't know what the initial size is. So I think this whole concept behind you have to shape to this much, you must shape to this much, was based on what is going to happen after that. Irrigation. How deep is my syringe going to go? Can I fit a cone? Can I obturate? How am I going to obturate? Am I going to use warm vertical condensation, single cone, sealer only? So I think that whole premise of shaping to size X, foraminal size Y, was based on the subsequent next steps. We published a paper about 4 or 5 years ago, which many people don't like because it does not fit that narrative. We extracted vital premolars, which we know have a large canal to start with. So we shaped them to either a 20 or a 40. A 20 in a lower premolar hardly touches the walls. We know that. So you could say the 20 was a sort of a sham group. We then did syringe irrigation and ultrasonic. When we did ultrasonic, the 20 preps were as clean as the 40 preps. So I think once the context of irrigant activation comes into play, at least in vital pulps, the preparation size does not seem to be a significant player. And I have maintained that take. I stop my preps with 25, I use a 4% taper, and I activate.
Yeah, it should be just enough to have efficient irrigation and disinfection protocol, and then to be able to obturate in
Absolutely.
properly. And I will have one more question to Professor Xenos about equipment. When evaluating new activation devices, how do you separate theoretical benefits from real clinical impact?
Now that's a very good question. When I need to evaluate irrigant agitation devices, as I said before, in the lab, everything can do the work. I mean, you set up all your variables as you want. You put everything, you test it the way you want, and then everything seems to work. But this is, as you said, theoretical. In clinical practice, we see that it doesn't matter that much, or at least when we want to improve outcomes, we need to define beforehand what kind of improvement are we seeking. If we're talking about 5% improvement, then it's practically impossible to perform a study with sample sizes that are going to show this kind of improvement. So it's very difficult to not to be, let's say, pulled in by all the laboratory research. Don't take me wrong. I love laboratory research. I have done a lot of laboratory research. I believe that we should rely on in vitro data to build on our clinical cases, but it's very hard. We should always discriminate actually theoretical from practical knowledge, and when we talk about practical knowledge, we need to go to the clinical practice, and then we need to find good studies, good randomized clinical trials, if there are any systematic reviews. We need to rely on the highest hierarchy of evidence if we want to put things in order.
We need to have strong theory to go into practical part later, right? So great discussion so far. So now let's talk a little bit about controversies and clinical risks. And Professor Prasanna, sodium hypochlorite is both indispensable and toxic, right? And why has no alternative matched its profile?
It is indispensable, agree. Toxicity only if you actively, forcefully extrude beyond the apex. If you limit to within the root canal space, it's not toxic. Well, it does break down the dentine collagen reasonably if you leave it for a long time for higher concentrations. Why has nothing else matched its profile? There are potential irrigants out there, like the peptides that I told you, which could match the profile. But the cost factor is likely the biggest deterrent. So it's not that we don't have alternatives, we don't have equally financially viable alternatives. Once that comes into play, then we have dozens of alternatives out there.
It's efficient, but it's not user friendly because of the price, right?
Yeah, and
Exactly.
Right now, maybe in the
Exactly. Right now, exactly. That is the situation. Yes.
and you know, we always talk about sodium hypochlorite. We always emphasize the antibacterial killing capacity that it has, but it has a property that I think no other irrigant has. It's a tissue dissolving capacity, and when you want an irrigant to have tissue dissolving capacity, how do you expect not to be cytotoxic? You know, it's two contradictory things. But if we irrigate safely, I wouldn't say that cytotoxicity is a huge issue nowadays. I wouldn't put it on the first top in the rank of problems with sodium hypochlorite, to be honest.
So one of the protocols which I have been using for the past 10 years now is dual rinse, which is continuous chelation. And I think Matthias Zenner did a fantastic job discovering and designing this concept. Well, it still uses hypochlorite, but the fact that you don't use a sequence means you don't produce a debris layer and then you're fighting to remove that debris. And what the what the etidronic acid does also is that it helps the hypochlorite penetrate deeper into the biofilm. So there is definitely a better anti-biofilm effect than what you see with the traditional hypochlorite EDTA protocol. So if at all we see a potential replacement for existing clinical protocols we have today, I think the closest we have right now is replacing a hypochlorite EDTA hypochlorite protocol to a continuous chelation protocol.
And one more question in the topic of controversies to Professor Xenos.
Yeah.
As an educator, how do you help clinicians navigate controversies when evidence is incomplete or contradictory?
Now, the first thing I say to clinicians or students that come with, conflicting, with being puzzled about the evidence we have, I say embrace the ambiguity. I mean, you have to learn how to live
That's
with
right.
these controversial issues, knowing our knowledge being incomplete doesn't mean that we need to throw up our hands and say we know nothing, but instead of that, it should empower us to be more critical and go dive in and learn more and try to learn more. Um, as I said before, I mean, it's just a matter of evidence. Rely on good evidence, solid evidence. Uh, be critical. Be critical doesn't mean to be judgmental, because there is a tendency, especially when it comes to in vitro studies, we are all being very judgmental, and we try to pinpoint all the flaws in the methodology. Try to think that these people they had a hypothesis in their mind, acknowledge the limitations, try to see whether these limitations hinder clinical practice. And regarding clinical studies, I think we should go to the highest level, and that's randomized clinical trials if we can, because it's not easy to do a randomized clinical trial, of course, and rely on good scientific principles. Rely on what you know. I keep telling that, but it's the only thing I keep telling to my students, because they keep coming with questions that I honestly I don't have a yes no answer to.
Simple answer.
I have to accept, I have to live with that, and I want to show them that you need to live with that as well.
Professor Prasanna, would like to add something?
Now, as clinicians and clinician scientists, we all have biases. We all have rather strong biases. And in fact, when I give my lectures, my first slide is not everything needs a clinical trial. And then I cite two papers from the British Medical Journal on whether parachutes are required to jump out of a building. And the conclusions were that there is no clinical trial on this topic and we need volunteers. So I think the problem with clinical trials is that now let's say, I'll be very honest, I do not like clohexidine as an irrigant. If I'm designing a study, there will be an inherent bias no matter how much you try to avoid it. There will be a bias when you are recruiting your samples in terms of what kind of lesion sizes you want to have. I can select what kind of patients I want. So if you take a look at the endo literature, you spoke about variability. The remarkable variability is because of such a heterogeneous study design. where things could be simple. It's not that case. So I could take a periapical lesion with a score of 1 or 2 and expect to have, or I could report no significant difference in healing. How much healing am I expecting in a score of 1? There is no lesion to start with. So there are studies of that nature as well. So when I look at studies with differing points of view, or students come with that, the first thing I tell them is go to the methodology and see if it makes sense. How does that fit the entire narrative of, is it a clinically relevant problem that you're addressing? A study, let's say, comes with a periapical index score of, let's say, 3 or 4. And that study, if that shows no significant differences, fine, it's a valuable result. With a periapical index score of 1, you will not see any result whatsoever. So I think we probably have to go a bit more, dive deeper into the methodology and look at every potential attribute. The second thing we don't speak enough about, I'm not sure if this is going to be censored, is conflict of interest. How many authors declare conflicts of interest when they perform studies? I don't see many in aeronautics. And that I think is very, very important to declare. And that any study which has a sponsorship must be taken with a grain of salt.
Of course,
Yeah,
very nice.
and to add on that, we always need to dive more into the methodology of whatever study we are reading. I mean, there is a study from 2013, and I think it was one of the first randomized clinical trials from with Luc van der Slaus and the Chinese group of researchers, where they had single-rooted teeth enlarged to apical sizes of 50, 60, and no significant difference was detected between ultrasonic agitation and no. How do you expect to find a difference when you have done all these clinical steps before? So we should be very critical when we read
Yeah,
something. We
that's
should
true.
dive into the methodologies and check whether everything applies to our clinical cases
Yeah, that's true.
first.
That's true. I agree. And because we are limited in time, let's have a deep try to dive into the future and think what could come in next days, next months, next years. And Professor Prasanna, antimicrobial peptides, nanoparticles, and photodynamic therapy are promising on paper. And in your 2024 review, you emphasized antimicrobial peptides as candidates. What is the realistic timeline for clinical translation, in your opinion?
Now, clinical translation to non dental applications, I can tell you, could be 4 to 5 years. Skin applications, we can do clinical trials. Dentistry typically lags behind by quite some years for us to adapt. So I don't foresee a dental clinical trial happening in this area for at least the next half a decade or so. That's for sure. Because you will have to design and develop optimal formulations. If you take a look at the only thing, like when we spoke about alternatives, I wanted to mention this. Chitosan, for example, photodynamic therapy, the one from Anil Kishan. There's been tremendous amount of work that's been done, and that's something which is finally in the market today. But it's taken several years because there are so many questions to be addressed. So when I see products being launched in a month, the research underpinning that is far from anything. But with Chitosan, there's been research over the past 15 years, so there's solid science behind what's happening. So that is a potential. We've also been developing natural compounds to prevent infections from happening. I see that as translating quite quicker because natural compounds has an established safety profile and it's cheaper. So that could translate maybe in the next 2 to 3 years maximum.
Great, great. And now I'll have one question to both of you to have a small discussion. Looking ahead to 2030, let's say, what will redefine disinfection in endodontics? Smarter irrigants, biofilm targeted agents, dentin friendly approaches, or a paradigm shift toward pulp preservation and regeneration?
A magic bullet which can do all of this.
We take
It
our
will be
magic
perfect.
wand and we do everything.
So we need a multifunctional therapeutic. And the reason why we said peptides are candidates is because they are multifunctional. They can eradicate biofilms, they can modulate the host immune response, they can promote healing as well. So what we really want is a magic bullet. And from a clinical standpoint, it is appealing because if I have one thing which can do multiple things, that is much more appealing to a clinician. To a scientist, yes, but to a clinician, a single bullet is more appealing.
And I think
And
we
Professor
are
Xenos?
trying to let's say to have this magic bullet already with this continuous collation concept. We're already combining two stuff that do multiple work. So we should go to multimodal irrigation protocols. One size fits all. It's very difficult to find, but we should strive for that because, as Prashana said, from a clinician standpoint, we should be not simplistic, but keep it simple. So if you add more and more and more things, at the end of the day, nobody's going to adhere to such irrigation protocols. Probably we can add peptides, we can add DNases, we can add whatever there is, chitosan, a lot of stuff, nanoparticles. But how much is this going to cost? And
Yes.
what is the improvement that it's going to bring? I don't know, to be honest.
To be user friendly, as we told before about the
Exactly.
price of peptides. And I will have two more questions, one for each of you. And Professor Prasanna, what are your thoughts on the relationship between ATP levels, disinfection, cleanliness, and outcome? Or can ATP level be used as a surrogate
I
endpoint
was
for
hoping you wouldn't ask this.
I needed to.
Now, ATP is a molecule produced by anything which is biological, right? Could be mammalian cells, bacteria, anything. Given that anatomy is so complex, how am I ever going to sample from the entire root canal system to know the profile? I can do it from the main root canal space, right? This goes back to what we were doing with culture based techniques historically. Take samples from canals, try to culture them. I, well, I've not done anything specific on this, but conceptually, I am not very confident it's a robust strategy. Also, I know this system gives out numbers. What do the numbers mean? How do I know clean is clean? Because I know I'm never going to have zero, right? But what is 20? What is 50? What is 80? I don't know, right? And if I take out material from inside the root canal and I want to put them, let's say, into a broth culture, would the broth culture also give out readings for ATP for me? I don't know. So I think it's still too premature to call that into judgment. It definitely requires proper testing with multiple clinical situations.
Sure. Perfect. And as I promised, one more question to Professor Xinos. Do you think tools like ATP meters could realistically help clinicians decide when enough is enough during
Now,
disinfection?
that would be magical to happen if we could have a device to tell us, okay, now you have cleaned enough, go on with your obturation. That would be fantastic. But to be honest, I don't believe that we're going to have this thing. First of all, we need to develop clear cutoff points of when it is clean. I think that's impossible, if you ask me. We go back to the sampling problems. We have the sampling problems since the 1960s from the Scandinavian research where they were culturing, we were putting everything in an oven and see whether it comes up with bacteria or no, and we're obturating or not. It's the same thing. The only difference now is that we rely on, let's say, a more sensitive technique. But as Prasanna said, it detects everything. ADP is everywhere. How do we know that we don't get false positive results? For example, maybe, I mean, it's a very crude way, maybe, to see whether we need to go further in some cases. For example, if you sample and you see that you have a lot of light, because we talk about bioluminescence, then okay, you say, I will irrigate some more. But that's the maximum that I can see at this point from these ATP meters, to be honest. Maybe I'm proven wrong. I hope I will be proven wrong, but I don't know. I'm a little bit skeptical on that.
Wonderful, wonderful. Thank you very much. Would like to add anything as
And I
the
said,
final?
we
Great,
hope it
great,
works. If
perfect,
it works, we have
perfect.
something clinicians can use,
Yeah,
but my
that's
hopes are
right.
not very high.
That's right. So wonderful. Thank you very much for this fantastic
Thank
Thank
you.
you.
discussion.
Thank
It
you.
Interview.
was great.
It was great to have you here and that you shared your time with us at the ESC Live Studio. Thank you very much for watching us here offline and online. And see you tomorrow during next activities here. See you.
Thank you.
Thank you very much.